All right, welcome back. You're watching Morning Cafe, and this morning on Health Thursday, we take a look at infertility, the medical facts, the societal perceptions, and the solutions available. To help me with this conversation is Dr. Stephen Ngigi, a family medicine specialist. Welcome back to studio, Dr. Good to have you again.
Yes, thank you. My name is Dr. Stephen Ngigi. I'm a Deputy Director of Medical Services based in Murang'a County.
Amazing.
And a senior family medicine specialist.
I want us to jump right into demystifying infertility.
Yes.
It is a widespread concern today. What would you say is the main cause for this?
I would say that how we define infertility is when we look at both gender, male and female, persons of reproductive age who have been engaging in unprotected sexual intercourse in an effort to have a baby without using any family planning method for more than a year, and they are not able to get a baby. The reason why we also emphasize that male factor should be looked at seriously is because we have observed a trend where it's usually the burden of proof is left on the other gender, and that is quite unfair. So the etiology, what we would say is that there are those causes that we call congenital and those which are acquired. We have in female, we have factors that we look at, like hypogonadism. Small, the ovary may fail to develop. You may have polycystic ovarian disease, which is maybe congenital. For men, you may have cryptorchidism, that is undecided testes. We have also seen people who tend to have deformities of the reproductive organ. We talk of hermaphroditism. We talk of imperforate hymen. We look at people with abnormalities of the uterus, like uterus didelphys, unicornuate uterus. All these are among the factors that may congenitally have developed when someone was still a baby, and they end up causing infertility. However, we have other factors like the acquired ones, which are quite common causes of secondary infertility. The common one is chronic pelvic inflammatory diseases, which are, we refer to as sexually transmitted diseases, like chlamydia, like gonorrhea, group B strep. These ones, what they do is they tend to cause inflammation of the tubes, and then fluid accumulation. You end up with what we call hydrosalpinx in women, and in a way they prevent the ability of the ova to be able to migrate from the ovary so that it can implant itself in the uterine cavity. Other conditions that we have seen, acquired conditions, are diseases like tuberculosis, peritoneal tuberculosis. Some of these patients are presenting with the TB of the ovaries. We have seen men with the TB or chitis, that is tuberculosis affecting the male organs. When they have these conditions, it is quite difficult also for them to conceive. However, we also have got lesions. Lesions are abnormal growths that can occur within the reproductive system and prevent a woman from conceiving, like leiomyomas, or commonly referred to as fibroids, which can grow in the submucosal area, intramural, within the uterine wall, or subcallosal. So the submucosal ones will tend to cause heavy cyclic bleeding and they might cause recurrent pregnancy losses. I've also encountered quite a number of women who conceived when they had these fibroids, and the baby died. Either they had intrauterine fetal demise, or immediately after birth, they lost that baby. So those are some of the things that we see causing secondary infertility. We have a condition called antiphospholipid syndrome, where we see women developing certain autoimmune antibodies that tend to lead them to have recurrent abortions. Most of these women are also prone to high blood pressure in pregnancy, what we normally refer to as PET, or pregnancy hypertension peculiar to pregnancy. There are other factors like endocrinopathies, diseases that when people have them, like we are seeing a lot of women now with goiter. Goiter is a swelling of the thyroid gland. And a good number of them also having a challenge conceiving. Diabetes type 2. We are seeing those women who have diabetes type 2, they tend to have a triad of that diabetes type 2. They may have the ovarian disease, polycystic ovarian disease. Cyst? Yes, polycystic. Then they have type 2 diabetes and also a rare condition called meningiomas. Women with metabolic syndrome, hyperlipidemia, glucose intolerance, obesity, again, they are having a challenge. So the factors are quite many. So we usually categorize them the way I have said, congenital, acquired. Maybe there could be a history of trauma. Trauma, somebody may have had testicular torsion and the testes had to be removed. Especially young boys, when they are playing football, they fall and get injured in that organ. They may have problems of conceiving. Men who are on antihypertensives and even diabetics, most of them are coming with challenges of low libido. They are unable to, they have lost their ability to perform sexual acts, and in a way it will lead to some secondary form of infertility.
Now talk to us about, you've touched on a lot of things, but I want us to narrow down to when men and women, we are most fertile. And now what leads now to us now being infertile, or if it comes later on with age?
I would say that for the acquired one, of course, people are more fertile when the WHO looks at it, at least above 21 years of age.
For women?
Because both the gender, we consider that 18 years is still somebody who is young, is a teenager. But at least by 21 years, we consider them to be young adults. And between that age and 35 years, that is a good period of considering issues of reproduction. When things start going beyond 35 years of age and approaching 40s, that's when we talk of elderly primigravidas. And it has its own risks of what I have said. They can have hypertension peculiar to pregnancy, what we refer to as preeclampsia, which might predispose to pregnancy loss. You see, with our men, there are other challenges they are facing as they grow because of socioeconomic issues. They're indulging in illicit drugs, alcohol and smoking, which could interfere with their sperm count. You end up with oligospermia. That's a sperm count below 10 million per male. You can have, azoospermia, where you don't even have any sperms at all. You can have something called asthenospermia. The sperms are there, but they are not motile, and you see they can't move. Or tetrazoospermias, a sperm with abnormal heads, or abnormal tails, or the abnormal body. So we are seeing that in people who are taking a lot of illicit alcohol and smoking, tobacco and bang and chewing cat, all those kind of things.
When you talk about sperm count, what is the desired amount, a sperm count that somebody should have for them to be proven fertile?
You see, when we look at it, we call it seminalysis. When we look at it, at least a count should be more than 20 million per male, or if it is between 40 and 80 million, we look at the percentage of the sperms that are normal. The percentage should at least be above 40%, approaching 50%. Because what we are seeing, you can see there is a normal sperm count, but you discover that a good number of those sperms are not motile. They are not moving. They are agglutinating, meaning they cannot reach their destination. The other thing is the abnormality, what I have said about tetrazoospermias. We look at whether they have abnormal tails, abnormal head, And all these things have been caused by excessive consumption of alcohol and smoking. Then we also, you know, the total, among the total count, we look at the percentage that is normal versus the one that is abnormal. Then we can say whether someone can conceive or not. But the more worst case scenario is where we find no sperm, the azoospermia. Because azoospermia could mean that this is somebody who has never had any sperm since they were born. Yeah.
Such cases exist, you know, where somebody doesn't have sperms at all.
Yes, we are seeing them on the lice. We are seeing so many cases of azoospermia. And that's why I was talking of the congenital issues that could be related to that. Yes.
And when you talk about, sometimes you notice abnormal sperms, their tails are abnormal, the head is abnormal.
Yeah.
Is there something that you do to remove them, or do you just leave them there?
In scenarios like that, because those are people having challenges of conception, you see we have the assisted reproductive technology technique, whereby the normal ones can be harvested and then artificially inseminated to an ova and then implanted in the uterus. Or we can do what we call intracytoplasmic sperm injection techniques, or in vitro fertilization.
That is IVF.
Yes, the IVFs, yes.
Okay.
Yes.
We started by saying that sometimes the burden is put more on women.
Yes.
Why aren't men not talking much about this fertility, or are they now coming up to explore, to go to their women and to test if at all they're indeed fertile? That's
a quite a challenge, because society usually there is that tendency to leave the burden of proof to the lady. And many times women have come, they have done all sorts of tests, hormonal profile, the heterosalpingogram is normal, peritoneal spill, ultrasound scans are normal, they have no lesion. And still, when you take their hetero, their cycles are normal, the menstrual cycle. So eventually you have to get the other gender to get involved. But you see, the lady has already, gone through a lot to prove herself fertile before the man comes. But I think there is an element of stigma. Society has that element of stigma when it comes to issues of fertility. So to get the man, especially if it's somebody who is abusing drugs like alcohol, smoking and all that, it's difficult to convince them to come to the hospital for checkup. I have seen actually a lot of times we write a prescription for seminalysis. We give the lady, she goes and convinces the man to go for the test. Because he will not even come to the hospital. Then the lady will come with the results. Now the problem is when she comes to the result and you see this is azoospermia. Yeah, but you see the society puts a lot of pressure on the lady to have, if there is no child, the other people tend to think, they even mislead the man to look for another. You will see them looking for several wives and things are not working.
And most times it's the men.
Yes.
Interact with us. This is a very interesting conversation. We are live on social media platforms, TV47 Kenya on Facebook and YouTube. There is a number on your screen as well. Call in. We'll be glad to hear from you and to also just sample the comments that you have regarding this particular conversation that you're having on infertility. Sometimes they say that we've heard of other contraceptives that women use.
Yes.
That's most of the time they are the cause of infertility. Just to mention one, while I was doing my research, I noticed that some women complain more about Depo.
Depo injection.
In Depo injections. And I don't know how true that is, but from a medical perspective, maybe you can now break it down for us.
You see, Depo is an injection that is given after every 3 months, and the issue of Depo is that the cycle will be there, but it will be inhibiting ovulation. So you'll have an ovulatory cycles, and sometimes you might have spotting, meaning you might see bleeding here and there. You see, it seems to reverse the biological clock of the pituitary gonadal axis, the hormonal axis, because normally the pituitary gland is the one that is producing the follicle stimulating hormone, anterior pituitary gland, also the luteinizing hormone. And these hormones are very important when it comes to stimulating the ovarian follicles so that the ova can grow and mature. So it tends to slow that. So now when you stop the depot, because of the high doses you have taken of the depot, there is a tendency for biological clock to delay. The biological clock meaning that there is a tendency for this FSH, LH axis to delay. So many of these women will come with a delay in the fertility. So we cannot say they are not fertile because they have given birth to children, one or two.
Yeah.
Then probably they will have to be put on hormonal, stimulation for ovulation. And we have those drugs in the market which we give these women to try and again stimulate the ovary to produce the ova, the egg.
Keeping it ready.
Yes, yes. We have them like Promid and we give them to these women. So that's not a difficult one to deal with when it comes to fertility.
Okay.
The two difficult ones I've told you is where we have azoospermia, where there has not been any sperm, so that it becomes even difficult to do artificial insemination, in vitro fertilization and all that. Actually, the difficult ones are on the side of men. It's not usually on the women. Fertility issues with women is not very difficult to deal with. Unless they have now what we are saying, the ovaries are not producing the ova. Yeah.
We have a call right in at this particular point. Sharon from Busia. Good morning, Sharon.
Morning.
Talk to us. Good morning.
Napenda hii kipindi ni mzuri sana, inatuelimisha. Sasa mimi swali yangu ni moja.
Okay.
Unajua mzee wangu mimi tumekuwa tukijaribu kupata mtoto kwa miaka 5 nusu.
Okay.
Na kusema kweli, nimeenda kwa madaktari, wameangalia, lakini hakuna kitu.
Okay.
Sasa nashindwa. Shida iko wapi? Kwa sababu mzee namjaribu aende twende hospitali na yeye inaweza kuwa yeye ndiye akona shida lakini anakataa.
Okay. Thank you so much, Sharon, for your question, Daktari. 5 years they've been trying.
And that's why we allow them to they cannot just stay in Busia. They can go to the level 5 and 6 facilities like in Kisumu. There are fertility experts there at the Jaramogi Oginga Odinga Teaching and Referral Hospital, where they can start considering other things. Because what we have observed is people are coming to us at 50 years of age, telling us they have been trying to conceive for the last 10 or 15 years. And that's not a fair thing because probably they have only been going to one clinic. And there are limitations. Some of these facilities, they are not able to do hormone profiles. They are not able to do some of the complicated tests. They can't have in vitro fertilization where she is. We don't have assisted reproductive technology in most of the counties. So they would need to come here in Nairobi, Kenyatta National Hospital, where we have a fertility center so that they can be looked at, because 5 years is a long duration of time. And you see, the people who exert pressure to such a lady are the extended family members. Hey, you people have been here for 5 years and we are not seeing any results. So it becomes a serious societal, psychosocial issue. Yeah, the mother-in-laws are usually, especially on the neck of the lady.
Okay.
They put a lot of pressure. Yeah.
So at what point should a couple now be concerned and say, let's get help?
I've said once people have tried it for more than a year, they should start seeking treatment. They should start going to visit a fertility center. There is something called preconceptional counseling and care. Even when people are planning to conceive, they should go to see the doctor. They can see us, they can see the obstetrician gynecologist who will evaluate them. People in this world tend to wait and hope they will conceive or somebody will get pregnant. Sometimes that will not happen. So preconceptional care will involve evaluation. People are checked, they are screened for various diseases, including diseases we call like torches, diseases like toxoplasmosis, diseases like syphilis, okay? Immunosuppressive diseases like HIV, cytomegaloviruses, because they have all been shown they can have a problem with conception. We call them the torchesas. Yes, rubella, all those things. We are supposed to screen somebody, but people are just coming when they are pregnant and they are sick, and that's why we are also seeing a rise in a lot of deliveries where the baby is having abnormalities.
Okay.
And even we should know their hemoglobin levels, introduce folic acid supplementation, even preconceptional for those high risk women, because those are the ones who are giving birth to babies with the spinal bifida, babies with meningomyelocele. Hydrocephalus. All those are neurotube defects which are very stigmatizing and a big problem in the society and very expensive to treat. And you only need folic acid supplementation. And it would work during the first trimester. But people are coming in their late second trimester when everybody in the village can see they are pregnant. By then, all organogenesis has taken place. Malformations may have occurred if there was folic acid deficiency. So even when we start IFAS in that trimester, it doesn't help that baby. Yeah.
We've heard about cerebral palsy as well. Does it come at that particular point when now no enough medical checkup is done?
Definitely, that is part of it, because you can have cord accident. Even before term, you can have cord compression. You can have cord knotting. When we talk of, space occupying lesions, the mother has conceived and there is a fibroid there. They are not attending a high risk antenatal care clinic, focused antenatal care. They might have a risk there. People with the oligohydramnios, there is very little amniotic fluid there. There are risks there to the baby. Already there is injury occurring even before the baby is born. People who have preeclampsia, they have hypertension in pregnancy. They're having a problem already. Diabetics. There are those people who even get the gestational diabetes. They are not aware because you see the body changes. When people conceive, the placenta tends to alter some things by producing hormones we call HPL, human placental lactogen, and human chorionic gonadotrophin hormone. And some of these antagonize insulin in the body. So it increases the drive of insulin between the maternal-child placental barrier, because the idea is to nourish the baby, but it prevents the mother from utilizing the glucose by antagonizing the insulin. So all those mechanisms, you cannot tell them at home. You cannot be able to tell that someone is developing gestational diabetes while they're at home. They need to come to us. We need to evaluate them. We need to check if we screen them even for diseases like syphilis, diseases like rubella, toxoplasmosis, cytomegaloviruses, because these are immunosuppressive diseases like HIV. Because you leave it to chance, then you increase even the risk of mother-to-child transmission of HIV, rubella, toxoplasmosis, and that child will be a big problem. You'll have a lot of problems with that child.
Okay. I want us to go back to the point on contraceptives, and I know you mentioned that we're talking about Depo, and you say that it's easier to deal with it.
We even have Humble. There are those who are using some Humble medications coming from Asia, like Yasmin.
Okay, now the question was, we've heard a lot about contraceptives, some contraceptives causing infertility, kabisa, like something that cannot be reversed. And we've had mostly with the over-the-counter, the P2 one, that sometimes you use it for a very long time and you end up becoming infertile. Is that really true, or can it also be helped? Just as the Depo that we talked about.
Why would someone, if they are using P2s, then it means they should have a long-term method of contraceptive or a medium-term method of contraceptive. Surprisingly, we are seeing college, students and people who are not even married using contraceptives even before they have a baby. And probably that can pose a challenge, like you are saying now. The time they want now to have a child, it can become a big problem. Because you find someone has been put, is having already an implant, and is a student. You see, but she is of reproductive age, and the parents are worried because of their behavior. They can see this one might bring us a child at home, and we want her to study. So they go and get the family planning. So in scenarios like those, now when they will want to conceive, that's why I'm saying they need to come fast. and see, see the doctor. They are evaluated, their hormonal profiles are done, so that you can tell they are ready to conceive. They are screened for sexually transmitted diseases like syphilis, HIV, toxoplasmosis, and all those things I'm talking about. Many times I've said, because people, this is not a topic that people like discussing openly. And this is even partners will not discuss among themselves about it, because none wants to admit the other could be the problem, and especially when the man is involved. So it becomes very stigmatizing and difficult to, like now, a man with azoospermia, they tend to hide behind alcoholism and drug abuse. The moment they discover they have that problem, and they can be violent. They don't like it when you keep, pressurizing them to have a baby.
So you recommend not using contraceptives for women who've never given birth? If you are
abstinence would be the ideal thing, because you are in school and you are studying and you want to become a doctor, or you want to be an IT expert or a lawyer. The ideal thing is you go and study and concentrate. But because of the dynamics of changes that we have seen in society, and of course, there is a likelihood of, the environment might encourage them to indulge in some of these activities, which, they end up having what we call unplanned pregnancy. So abstinence is a family planning method.
Of course, we also have condoms. Last week was International Condoms Day. So that you would recommend that?
We usually have dispensers, especially now because of HIV and all that. Dispensers have been installed, or it's part of primary care, work by the government. Like in hostels, in areas, public places and all that. We have condoms and condom dispensers, because that prevention even of disease like HIV is better than, worrying a lot about how much medicine you are giving people. Even diabetes, we have an elaborate program under the SHA relating to primary health care. I'm a primary health care specialist too, where we are doing a lot of health promotion in the community units. And, these CHPs, the community health promoters, their work is to walk in the village, be our ambassadors, talk about these diseases we are saying, educate people about screening for diabetes, for HIV, for tuberculosis, refer them to us promptly in level 4 hospitals for checkup. Because the ideal thing about health is prevention, it's not cure. You cannot say we will have a lot of stocks of drugs to give people, so we leave them to get sick. No.
All right. We have a call. We have a Bruce from Kakamega calling in. Bruce, how are you? Good morning. Hello?
Hello?
Yes, Bruce, how are you?
I'm good.
What is your question?
Naitwa Bruce kutoka Kakamega.
Okay.
My question to Dr. is, how do you know as a man, you have low sperm count, and what causes infertility?
All right. Thank you so much, Bruce, for your question.
Yes, thank
you, Bruce from Kakamega. I have worked in Kakamega Provincial General Hospital in Western Kenya for some years back. So issues of knowing is about a person, and that's why we're talking of health promotion. Is about taking a proactive role. As the man, you should be the leader. You should be leading. Level 1 of healthcare, in healthcare, system is the household. The head of the household is the man. That man is the one directing issues of health inside the homestead. It's not the doctor. So he is supposed to go with his wife to Kakamega Provincial Hospital. There is a gynecologist there, obstetrician. They can sit and be evaluated. Their laboratory is well equipped there. It's capable of doing seminarises, routine, microscopy, swabs and all that. The hospital there is well equipped to do hysterosalpingogram, ultrasound scan. I'm talking from, I have been there, so I know they have all that. And they have people there who can handle it. If it turns out that probably he has low sperm count, it may require just medical treatment. If it is caused by an STI, they can be treated. If it is tuberculosis, the drugs are there. They'll be treated. And we know there are issues like laparoscopic surgery has been devolved in some of these units. So it is possible if there is an issue of hydrosalpinix or an issue of uterine fibroids, they can actually be handled there. Those ones don't need to come here. Yeah.
All right. Bruce, asante sana. We hope that Daktari has answered your question. Vizuri. Talk to us about PCOS. You know, sometimes you scroll through social media and you see nowadays PCOS is talked much about by women, and they have these fears that they are never going to get pregnant because they have PCOS. Is that really the case?
And actually, you see, these are silent diseases. Polycystic ovarian syndrome is not something you would know. Many people are having it and they are not aware. They usually discover they have that at the time they are trying to conceive. Or they start experiencing chronic pelvic pains. They are having dysmenorrhea, irregular cycles and all that, associated with probably surges of hormones and all that. Then you do an ultrasound scan and you see they're actually having polycystic, a lot of small but many cysts in the ovaries. And I have said that is a condition that has been associated with type 2 diabetes, the metabolic syndrome, people with hyperlipidemia, glucose intolerance, and all that. So early screening would do well for them so that they are started on medical treatment early enough to prevent them from developing secondary infertility. Because we are seeing a lot of young women with polycystic ovarian syndrome. Another condition that we are seeing is endometriosis.
Yes.
Yeah, those who are experiencing pain, and that is, when you have development of endometrial tissue outside the normal uterine cavity, it can be growing in the ovaries, it may be in the omentum, it may be here in the umbilicus, sometimes even in the pulmonary system. And it can be associated out of pain.
You're talking about screening being important before seeking for treatment, when in regards to PCOS. But what does one look out for exactly before now coming to seek for medical attention? Amekaa pale chini, ameona wacha niende screening. What are some of the signs or underlying factors that I can look out for?
You see, ideally, your menstrual cycle should be normal, meaning that it should not be associated with pain, it should not be too heavy, extending more than 7 days. Again, it should also not be just sporting, and it should not be associated with back pain. You know, there might be mild back pain, but it should not be that much. So when you notice you have irregular cycles, menstrual cycles, heavy bleeding, there is dysmenorrhea is the pain. Sometimes they even come to us and say there is a discharge. They are seeing that does not look, it looks more like chocolate colored discharge, and it is smelling during their menstrual periods. Then they need to be screened. The scans, the ultrasound scans will tell us if there is a polycystic ovarian disease.
Talk to us about the first in-line treatment for infertility now before going for the advanced one. What is the first in-line treatment?
Baseline things are baseline, and we have them in all levels of facilities. That's what I keep saying, because if we know, especially secondary infertility, if we know with screen and see someone has chlamydia infection, we just give them the antibiotic and treat it. If they have Neisseria gonorrhea, we treat it. If they are having Treponema pallidum, which are spirochetes that cause syphilis, we treat it. If they are having TB, actually there are several who have come. We discovered it was tuberculosis. We treated them full course TB, and they were able to conceive. So the treatment depends on what is the causation. If they have uterine fibroids, we have done laparoscopic myomectomy, embolization, medical treatment with some hormonal medications that help to shrink them. You see, so these are not things that are not available. These are routinely available in level 4 and level 5 facilities, and a big number of women are benefiting at that level. If the tubes are blocked, they can be unblocked laparoscopically. We call it tuboplasty, where they marsupialize them. They open them up and do hydrotubation using laparoscopic techniques. So the treatment is there, and basically it is devolved. It is available. If it is an issue like what we are saying here, using depot and all that, we are giving them drugs to stimulate ovulation, like chromid. If you try all that and it fails, then you go for assisted reproductive technology. You harvest the sperm, and that is done here in Nairobi. Then you do in vitro fertilization, you do intracytoplasmic sperm injection techniques, artificial insemination.
Right. You've touched on assisted reproductive technologies, that is the ART, the ART, and the IVF as well. So what factors determine that a couple, they are a good candidate for IVF?
Of course, there has to be, like if they have oligospermia, the medications have been given, you have treated if it was caused by an STI, still they are unable to conceive, or somebody was abusing a lot of alcohol and smoking, which could have caused a problem. Then there is some normal sperms. If you see, the percentage is low to be possible for the woman to conceive, but they are there. So you harvest them, and those are the ones I'm saying you can give, you can do, then you harvest the ovum from the lady. Then you do in vitro fertilization, or you do artificial insemination. You introduce them directly into the uterine cavity, especially scenarios where maybe the tubes are blocked by hydrosalpinics or because of something that happened, but you want to harvest the ova, bypass the tube, and introduce it in the normal uterine cavity for conception.
When you talk about treatment being devolved and they're available at the level 4 hospitals, would you say that infertility treatments are available for average Kenyan? Let's talk about the one who is not maybe financially okay, and of course they want a baby. Are these options also available for them?
A lot. In fact, one of the things we are keeping telling our women, because we are seeing a rise in number of secondary infertility cases which are treatable, is if they have like SHA, they have at least a form of insurance cover. It is helping them a lot, because if they have hydrosalpinics, they go for tuboplasty, it is catered for by the insurance. If they have myomas, they go for a laparoscopic myomectomy, it is also catered for. The observation we are seeing is the slow uptake, because if you go, you come, you have those conditions that might require certain procedures or interventions, and you are financially not capable, what would help you is if you have a cover. And the easiest cover for everyone would be the one that is universally available at a lower cost. Because Mama Mboga can afford SHA, it's around 7,000 and something per year. And we are seeing them actually taking it up in the villages. Then they come, you screen them, you see they have those conditions, and they are treated at the level 4. So something is happening.
Okay. When you talk about facilities being devolved and facilities being there in the country, of course, for such medical issues, do we have enough specialists now to cater to infertility cases in the country? The hospitals are there, but do we have specialists?
We may not have enough, of course, because we are many, but we are better off than we were some years back, because there were years back where people used to go to other countries to look for in vitro fertilization. That is not happening now. There were years when people had to travel from up country to come to Nairobi for a laparoscopic surgery. Today we even have our gynecologists who are actually moving around and able to do it in different facilities with the laparoscopic machines. So there is an advantage of the spread out.
Just hold on to that. Just hold on to that. Doreen is on the line from Bungoma. Good morning, Doreen.
Morning, too.
Talk to us.
Pardon?
Hello, Doreen.
Yes.
Can you hear me?
Yes.
What is your question?
My question is, hello?
Hello, yes, Doreen, what is your question?
My question is, I had a kid,
Okay.
but I always have painful period. Been unable to conceive again. It's now 13 years.
Okay.
I don't know is the problem.
All right.
So there is a time I visited the gyna. They checked there's something, the insertion they used, there's nothing in the uterus and whatever.
Okay.
So yes, but I don't know the reason is, but my period takes 21 days. 21 days, then you see it again. Sometimes 18, 19. Too painful.
All right. Thank you so much for your question here, Dr.
Yes, thank you. Bugoma was there in the year 2011, so I know Webuye Hospital. Some of these procedures can be done there. And what she's describing seems to be like hysterosalpingogram. You know, it's a technique whereby using a speculum, you are introducing a cannula through the cervix and introducing contrast, radioactive, whatever, opaque contrast, which goes to the uterus, and then you are looking for peritoneal spill, and that's why she's saying maybe there was some pain and discomfort. Probably they needed to give her analgesia and also explain to her. They didn't find anything, meaning she had a normal peritoneal spill. And that's why I'm saying was the husband part of the treatment. Because if you are focusing on the lady for 13 years, you know, did she have a history of ectopic pregnancy? Has she ever had an operation? You know, has she ever had an abortion and probably she developed some sepsis, post-abortal sepsis and all that? These are things that we can only tell if we have the couple. And then what I always encourage them is keep checking issues of infertility. Don't stick in one, you know, clinic. If things are not working, move on. If she's in Bugoma, she can go to Kakamega Provincial Hospital, the county hospital there. There's still a gynecologist there and they can look at her. She still can come to Kenyatta National Hospital for more checkup. Because the problem with years, when years start starting from 10, 11, 13, waiting for a baby, is the psychosocial impact and you know, it causes other illnesses, anxiety, depression, and I've told you it can even create highly expressed emotional environments at home.
Okay, just hold on to that. We have another caller. David is calling from Nairobi. David, good morning.
Good morning, madam.
All right, what is your question?
My question is, how safe is AMBO family planning medicine? And
how safe is what?
Safe?
David?
How safe are AMBO family planning medicine?
All right.
Yes, and how safe are they all better than the normal one in terms of safety and side effects?
All right. Thank you so much.
You see, the herbal ones have not been properly tested. And there was a time you had the Pharmacy and Poisons Board complaining about high dosages of those hormones in some of these herbal family planning methods that people are using. Quite popular among some women because you are just taking one pill and you stay for a long duration without taking another one. The danger with those ones is that we are seeing people coming to the hospital with issues of, like we have said, heavy bleeding, breakthrough bleeding, and lower pelvic pains. Then you scan them and you see they have got some abnormal growths in the ovaries and all that because of hyperstimulation by the herbal methods. We cannot quantify how much of the estrogen or progesterone is in these herbal ones. It is very difficult because they have not been properly tested. So, but we have a wide variety of free family planning methods offered in our government hospitals, in the family planning clinics. Like what we have just said, the condoms are there, dispensed freely. We have said you can have intrauterine contraceptive devices. They are there. We have Mirena, the IUCDs with no plant. they are available. The no plant itself is there. So the options are not limited. We have even now have the female condom. It's available there, the diaphragm. All those things are now available. Yes, they are.
That is too expensive, the female one. It's not available to the common mwananchi.
In the facilities, family planning clinics, we have these things. You see, the problem is the uptake. You know, the society, how has it been accepted? The people who are accepting that one is here in the urban areas. In the rural areas, we are still doing health promotion. We want people to accept it because it could be there in stock, but you are not willing to use it. Yeah.
All right. You are talking to us about ectopic pregnancy when the lady who said she cannot conceive for 13 years. And ectopic pregnancy is also being talked much about nowadays. Maybe you can also explain to us what it really is, what causes it, because I understand it's when, is it an egg implants itself outside the uterus or something? Tell us about that.
It is when, a fertilized ova will implant itself outside the normal uterine cavity. Once it is outside the normal uterine cavity, it can be in the fallopian tubes, it can be in the ovaries, it can be an abdominal pregnancy. We see them. And abdominal means the baby is just growing outside the uterus, right in the abdomen. And sometimes they grow up to term. They grow up to term, and all you will do is just a laparotomy and remove the baby. But you not remove the placenta because of issues of bleeding. Then they are given some cytotoxic drug to destroy the placenta. Because it is family attached outside. Outside the uterus. Now, an ectopic one that worries us is the ruptured. The one we say is growing in the fallopian tubes, then it ruptures. And just when the ova dies and it has ruptured, you will notice there will be, some bleeding, the shedding of the decidua, because the uterus, as the ectopic was growing, the lining of the uterus, the mature lining was also growing. When the ectopic dies after the rupture, this part of the uterus also comes out and there's bleeding. And that can create a confusion because somebody might think they're actually having an abortion, which is not. So an ultrasound scan is there in level 4 facility. It will be able to pick out a left or right-sided region in the fallopian tube. Maybe there is free blood in the peritoneum. And that is an emergency. Ectopic pregnancy is an emergency. So a laparotomy will be done, and probably when it's been removed, part of the tube will be removed, meaning that there is a risk also of infertility.
Male infertility treatments, you talked to us that indeed they exist, but would you say they're more effective as compared to women infertility treatments?
Well, they are not expensive because, if a man, is able to, with oligospermia, for example, they can still release the semen with some sperms. That is very easy to harvest and do the in vitro fertilization and the intracytome. It's not invasive. You don't have to do anything invasive. Yeah.
Do you have cases where both the couple are infertile? The woman is infertile, the man is infertile.
Of course, because if it's a sexually transmitted disease, it means it is on both. The man may be having it, may be having syphilis. The lady may also be having it. So probably chlamydia, the same thing. Someone is having orchitis. The other lady is having chronic pelvic inflammatory disease. Infertility is actually both. It is both gender. It is not one person. Yes.
Now you understand the question was, you're married, yeah? You and your wife.
Both must come to the hospital.
Okay.
No one should be left behind. Because the tendency is the lady, you see even the phone calls, who is talking? It's the lady who is calling.
All right. We've also heard of egg freezing, which is also gaining traction, and the women are saying that they're doing this to preserve their fertility when the egg is now free.
Eggs, even the sperms, they are also being harvested and kept, particularly by people who are going to war zones or places where, they don't know when they will come back. We have seen that in countries like in US, where people are keeping, even sperm donors. You know, there are people who think they have, extra qualities, and so they are donating their sperms, and people can go there anonymously and select, because maybe they are looking for those qualities those people have. All those things we hear about them.
All right. Of course, we have come to the tail end of this conversation, but what is your final remarks? Let's say you're talking to a couple trying to conceive, trying to look for fertility treatment that works for them. What would you say to them?
They should not wait for 10 years. Even waiting for 5 years is too long. Dead people come for preconception oral care and counseling in our level 4 facilities. Routine screening, because you see there may be no pain. People normally come to us when there is some pain in their bodies, but with the fertility issues, there is nothing. The only pain is psychological and of course psychosocial, because family members are putting pressure. Just come to us. As a couple, we do the evaluation. If it is something that can be managed at level 4, we will manage. If it can't be managed at level 4, we will refer you to the fertility center at Kenyatta National Hospital. Yes.
All right. Now, Doctor, a lot of people are trying to call in, but they're afraid to ask. Of course, you also talked about stigma. So where can they find you?
Yes, I said I'm a government doctor. So I'm a Deputy Director of Medical Services based in Maragua Hospital in Murang'a County, room number 22. And they come. I can assure you that the numbers of people who come there are quite overwhelming. They come. We see them from all walks of life. From as far as Mpeketoni, I see them coming from Isiolo. They come because they are listening. Even from Siaya, I see them. So this is, you see, waiting for 5 years and hopping into a bus and coming to a facility. The bus will arrive the following day. But 5 years means that you are just stuck there in Webuye or in Bungoma for 5 years. And the doctor is just here in Nairobi at Kenyatta.
Can they get your number? Ama they wakuje to hospitali?
I said I'm a government hospital doctor, so they can just come to the hospital. Room number 22.
All right.
They will find me. You see, the number is not really a big issue. They can ask from here privately.
Because there are people who are asking for that number if it's possible, if they can reach you. But if you're not comfortable with that, then that is very much okay. Thank you so much, Daktari, for making time for us. That is Dr. Stephen Ngigi, Director of Medical Services. Deputy Director of Medical Services in Murang'a County. Thank you so much for being here. Up next is Fitness Thursday. You're watching Morning Cafe. My name is Anne Odida.